Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast.
So today we're pleased to be joined by Anna Hutchinson. Anna is a clinical psychologist who's been practicing for 25 years, and she worked for a long time at the Tavistock's now infamous GID service, and is currently director of the Integrated Psychology Clinic in London. Welcome, Anna. Nice to meet you again.
Thanks for inviting me.
Hi, Anna. So you're a clinical psychologist specialising in adolescent mental and physical health. What attracted you to this particular speciality?
Good question. I think I was thinking back. Nobody's asked me that question before. And I was thinking back, and it immediately became, the personal and professional. So my first jobs were in fact, a lot of my jobs were in Great Ormond Street Hospital. And as a little girl, I had sort of life-threatening asthma and life-threatening allergies and eczema. I was really poorly, and I lived in rural Somerset, and I was referred up to Great Ormond Street. And so some of my very earliest memories were of this place, really strong memories of the rocking horses and the waiting rooms and things. And the doctors there, helped. So I think Great Ormond Street was in my psyche from a very early age. And so I sought an assistant psychology job there after my degree, and worked in neuropsychology, assessing kids pre and post operations to remove brain tumours. And then moved into a job that was between Great Ormond Street and St George's Hospital, working with early onset eating disorders. And that's when I started working with the adolescents. So from there, I stayed interested in both, and particularly enjoyed working with the adolescent group. I think so much change goes on when you're working with a young person. You're witnessing them going through sort of developmental stages in front of you, and I think it's quite a hopeful time in people's lives. It can be a lot of fun. And I think the interventions we do then can, have ideally, positive lifelong impact. And I like the adolescent energy. So I've spent my whole career working with, I always say to my team, there's a reason we work with adolescents.
Yeah, well, you put across the positives of that very, very clearly, Anna, and the way that you describe the link, it makes absolute sense, really.
Yeah, I worked that out today, David.
Sorry?
I only worked that out today.
Well, that's another progression in life.
Yeah, thank you.
So, but you moved on from that to something rather different, didn't you? You spent some time working in the gender identity disorder service at the Tavistock Clinic. And of course, the Tavistock Clinic is extremely famous for its sort of groundbreaking work over the years. But was the work that you found there what you expected?
Firstly, I didn't think I was moving on from that work. Essentially I was working still with medical teams and with the adolescent population. So it felt like a very natural job move. And some of the staff that I'd worked with in Great Ormond Street were also working in the gender service at the Tavistock. So yeah, I don't feel like I consciously or deliberately left those specialities, but was it what I expected? No, it wasn't. So I'd been, just before I moved over to the Tavistock GIDS, I'd been working two jobs, one in sort of perplexing or medically unexplained symptoms at Great Ormond Street with mainly teenagers, and one working in the physical, it was the chronic fatigue service at the time, and it's now called the Persistent Physical Symptoms Clinical and Research Team at King's with adults. So we're, sorry? Oh, I've frozen.
You froze just for a few seconds. Yes.
All right. Okay.
So
Where should I
you were
go back
just
to?
saying about you were just saying how you moved over.
Yeah, so I was coming from two areas. One was thinking very holistically with adolescents in development and thinking using lots of different models and formulations and exploring systems around them. And the other one was very rooted, really, it was CBT predominantly, but also research was rooted in that job. And so I presumed that that's what I was going to be working with. There was a research team in the gender clinic, and we were working yet again with adolescents. But pretty soon it became apparent that we were working in quite a different way, essentially. I mean, the most clear difference was that we weren't formulating, so for us clinical psychologists, the clinical formulation is really, I think, what distinguishes us from other professionals in some ways. The drawing together of hypotheses to try and work out what's going on for any young person. And we weren't doing that at the GIDS. It was very diagnostic led. And it became apparent very quickly that it was, Hilary Cass later called it diagnostic overshadowing, where one diagnosis becomes the focus of all of our work to the detriment, really, of any other diagnoses or things that are going on with a young person. And that became really clear because, one really good example of how different it was from my previous jobs was that in one of my previous jobs, I'd been working with a family where we had safeguarding issues because the family had they had a number of children and they all had different diagnoses, different physical presentations that were keeping them out of school. And social care were involved. People were worried about what was going on in this family. And one of the first young people I saw in the gender clinic was from this family. And I knew that there were a range of difficulties going on for the whole family. I knew about the previous safeguarding concerns and I sort of raised those and spoke to the system, spoke to the CAMS clinicians. And whereas in my other job, we'd been slowing things down, we'd been trying to open up thinking, applying lots of different ways to make sense of what was going on for the kids. In the gender clinic, we diagnosed, and this young person was one of the people who went on to the early intervention trial, where young people were put on puberty blockers from about 12 onwards. So an entirely different way of working.
Why do you think, Anna, that psychologists kind of relinquished formulation so easily within that service? Because that's quite unusual. It's often the source of tension, isn't it, in teams, mental health teams usually?
Yeah, it's a really good question. It really, I think, and I think this is still the case. I think because we were working with identities, it's an interesting presentation, isn't it? Because we're talking about the diagnosis at the time we were using DSM-5 was gender dysphoria, but the identity that was being brought into the room and that the children were presenting with really was a transgender identity, and there was very much a sense. There's been a sort of a human rights movement, hasn't there, in society to rightly protect people who identify as trans. And I think part of that movement has been sort of trying to express that this is something that is lifelong, that is innate, that shouldn't be stigmatized or pathologized. And I think that was the tension. So, the social pressure was to not formulate that would be offensive, pathologizing, stigmatizing. And we were, as a service, were so organised around gender and the diagnostic pathway that I think that kind of tension, the diagnosis took over, and we let go of those kind of skills for a number of reasons. And I think when people did try and formulate, there was quite a lot of pushback, both from sometimes young people and families, not always, but sometimes, but also from colleagues. So there was a kind of a policing going on, whereby that skill wasn't necessary in this young person's service.
Thank you.
So, Anna, it sounds as if you moved really from working in a kind of dynamic, in the sense of working with a whole range of variables to reach, whatever work or treatment option you chose, from that kind of setting to one which was much more menu driven, or you use the term diagnostic driven.
Yeah.
That must have caused a certain level of discomfort, or to use another term psychologists are fond of, a kind of cognitive dissonance. At what point did that begin to develop in you?
Well, from that very first case I just described, there was the beginnings of many questions. But essentially, I was working in the Tavistock, and I was working with senior professionals that, esteemed and respected and that I liked. And so initially I thought I just didn't get it. I didn't know enough, that there was something about this cohort of kids that maybe was different, and, that I was just ignorant. So initially I spent a good sort of 6 months plus trying to learn, trying to understand what was going on. Then I went away on my first maternity leave. I thought a lot about it on my maternity leave. Went back. And at this point, whilst I'd been away, the numbers of referrals had risen dramatically. And in fact, the team size had risen dramatically. So I went back to a very different experience of the gender clinic. And one of my roles was managing referrals, and they were landing on my desk. And it was very clear that week on week, these piles were getting bigger. And in referral meetings, it was getting very clear that these kids were, not all of them, but many of them, coming from very complex situations, had a number of difficulties beyond questioning their gender. And it was also becoming clear that whereas we'd always been expecting to see natal boys, birth registered boys with lifelong gender-related distress, what we were starting to see was this new cohort of females with sort of, it appeared to be later onset distress. So at that point, it started to be, I couldn't help but question. and what was interesting was that these, what was now sort of 60-70% female group were similar to some of the groups in terms of themes that I'd worked with elsewhere in eating disorders, and also in medically unexplained symptoms, perplexing presentations and things like that. And so of course then my formulation skills were kind of coming much more into the room, because I was beginning to recognise some of the themes. And that's when the cognitive dissonance became loud enough to want to sort of speak out. And initially that was with my colleagues, in the room with me. And it felt hard to do it, because there was still this pressure not to formulate, to simply support these kids in accessing what was argued to be life-saving treatment at the time. So I started talking to my colleagues, and a group of them were also worried. Some weren't, but a group of them were really worried. And then we went through this process of trying to ask questions, trying to speak to our managers, and eventually having to go outside of the gender service into the wider Tavistock Trust, and then outside of the trust as well in the end. So a process.
Yes, no, I can see that. And that must have been very uncomfortable, because clearly people have raised questions about loyalty and those kinds of issues. How did you manage those kinds of conflicts within your own role?
Loyalty to the team, or
individuals within the team, perhaps?
Yeah, well, both. Loyalty was a very big pressure. And it was a very tight team, and it was a very generous team to work in. So, we'd all been going through austerity, and often we'd go out and do sort of outreach work with the CAMS, and it was so clear how much more resources we had. We were able to still go to overseas conferences and things like that. So there were a lot of pressures to be loyal to the team, and there were a lot of very close relationships in the team, especially as the pressure was mounting and, trauma bonding. So it was a bit of a dance. I think I was sort of speaking out and then sometimes being pulled back into groupthink. There was a process like that for a while. But I mean, fundamentally, in the end, I had to make a decision about who I should be loyal to. And I decided to be loyal to the children because I didn't think they were getting a good enough service. So, yeah, a real process.
Thank you. Was there any sort of discussion within the team about what you've described really as a spectacular rise in referrals? Did people think about why this was happening?
It's hard to remember back because we're talking 10 years ago now, 2014, 2015. Yes. I mean, we were talking about everything all the time. In terms of what was happening, I think people were beginning to put forward hypotheses. Of course, the initial hypothesis at the time was that because of reduction in stigma, what was happening was this sort of natural coming forth of people who would have always been trans, but at a different time in history just wouldn't have come forward with that experience or obviously asked for help. And then gradually as it went on and it became clear, I think as it became clear that nobody wanted to think about why this was happening, that made some of us even more keen to think about what was happening, because you're having to think about what's happening with this young person in the room, or you're having to think about the patient cohort, but you're also having to think about what is going on in this system that we can't do, bread and butter work of a psychologist, which is number one, using our formulation skills, but also just questioning, just being curious, just having a broad view and an open mind about what we might be seeing.
Thank you. Do you think people were let down by psychiatry and psychology in this service?
Well, first, it wasn't only psychology and psychiatry. It was a psychology-led service, and it was predominantly psychologists in the gender team at the Tavistock. But it was also linked to the hospital UCLH, where we had endocrinologists working with us and nurses, and there were social workers in the team. So it was, and psychotherapists. It was a very diverse MDT. And a lot of people were. The immense pressure on us at the time, and over time, fewer and fewer resources. Considering that, I think some people are really doing their best to do a good job. And I think there were pockets of good work. But as Hilary Cass said in her review of everything that happened there, I think it's undeniable that they were let down. So Cass talks about the diagnostic overshadowing that I sort of spoke about earlier, but she also talks about basic data wasn't being recorded. Some really basic, not even psychology based skills, but some really basic fundamentals of any medical service weren't happening.
I was wondering, Anna, about I suppose thinking in a vaguer way about the responsibility of the professions of psychology and psychiatry and nursing and of endocrinology or what have you.
Yeah.
If people in the service were getting pulled into groupthink, what was there a letdown in terms of should the British Psychological Society or HCPC or the BMA, should they have been concerned? Was there enough for people to see where perhaps they should have been saying, hang on, what's going on? Was everybody just blindsided by the Tavistock and its reputation?
Yeah. Well, firstly, we had to get the information out about what was going on, because I don't think people knew. And I think that was a job that we had to do, first of all. In terms of, such basics weren't happening. The whole system was letting these kids down, regardless of what you think was or wasn't the right treatment, just basics. Consent forms didn't exist for many years, that kind of stuff. So that, I would say, the responsibility for that was obviously in each individual clinician, but also within, the gender service more broadly, and the Tavistock and NHS England. And then once the information was getting out into society that this was going on, yes, I think I think it's been a shame that some of our professional bodies haven't themselves been a bit more critical in their thinking, and we haven't yet. And I think it would be good. We need to do it at some point. We need to review why that happened, what happened, so that we can be accountable, and so that we can reduce the chances of that happening elsewhere or again. But we haven't yet been able to do that, And then you see it in psychology. There are different schools of thought, but some people still will say, no, there wasn't a problem in the gender service, and that treatment pathway was the right one, and that actually not continuing with it is the problem. And then you have people like me who are a bit more concerned about how it was working and keen to develop an alternative way of helping these kids. And you see that debate going on in psychology, and you see that debate going on in medicine. We've seen the BMA come in recently challenging the CAS report or the CAS review findings. So there's something going on systemically, isn't there, in our society that's making it very hard to even agree about what is happening, let alone review why it's happened and how we can do better next time. So yes, I think that we've let those kids down, haven't we? Yeah.
And also, I guess to some degree, also the professionals that worked there. If there's this pressure to conform, this pressure to groupthink in the service, and I imagine that it's probably quite difficult to look back and think about your own participation in that process.
Yeah.
So there's obviously the risk of moral injury to staff that worked in that service, and so I don't think it's just the young people. Obviously, they're the most important.
Yeah.
But actually, the staff that worked in that service have, to some degree, been let down too, I think.
Yes, and I think it's very interesting. So hundreds of clinicians went through that service because there was quite a big turnover because of the distress that was going on. Hundreds of clinicians went through, and maybe a handful have spoken out, and that's really curious, I think. And just from our relationships with our ex-colleagues, some people still believe that they were doing the right thing and that it was life-saving and that it was a brilliant service, but a lot, I think, have been really severely impacted by what happened there. And each individual has had to make a call about how to manage that and how to respond to it because the system hasn't been able to.
Yeah, and I think you were sorry, David. Did you want to say something?
Well, I was going to say, I think it's extremely rare for the leadership of any of these major professions to actually lead on controversial, problematic, difficult issues. It almost invariably depends on something going wrong and an investigation following, and there's nearly always very serious consequences for a number of the professionals actually working in the service. Sorry, that's just a comment about
that's right. And I mean, we
the Royal College.
Yeah, I mean, what you saw was reviews happening. So there was a review in GIDS in sort of late 2018, 2019 that concluded that it was all fine. So sometimes there's a performative element to the reviewing process.
I have heard the saying of kind of like inquiries being the place for bad news to die because everything can get thrown into that black hole.
Yeah.
And then people feel like there's a clean slate. But you kind of touched on, I think you were referring to kind of like vaguely about the sort of the lack of critical thinking that might be going on in wider society, and how to some degree maybe GIDS was reflective of that, this sort of polarised thinking and inability to reflect, or it's not okay to even wonder about things where there's a performative PC answer to that. But I also wondered whether there were wider implications for psychology as a consequence of the practices that should have us thinking about what happens when we don't have that critical thinking, because it happened in GIDS, but my guess is that could also happen in many other services. If it was just simply about the sort of lack of formulation and a handing over to diagnosis, well, that could happen in many parts of the system, couldn't it?
Yeah, I mean, it does happen, doesn't it, in many parts of the system? We know that. I mean, I think you take it out a bit more widely, actually, to the whole of evidence-based medicine. And you know the we did, again. Cass concludes this. You know, there wasn't the evidence base, she says, was remarkably weak, and yet we as a service were part of a pathway that was putting children through medical interventions that were dearly wanted, usually, always, but have definitely lifelong consequences when you go all the way through the pathway, and for which we have, you know, almost no evidence about the balance of potential benefits and risks, and that could happen to children in one NHS service if we aren't able to address it and to acknowledge it's happened and to be accountable in some way. I think, you know, it goes bigger than gender. I think that's a risk for the whole of evidence-based medicine, really. You know, if we can go this far off-piste in one area with children, despite all of, you know, the governance and the safeguarding that we have in place, and all our knowledge, you know, we know, like, clinical psychologists are highly trained scientist practitioners. We know what it should look like, but we could still go that far away from our best practice. Yeah, if we don't find a way to acknowledge that happened and put in place something to try and catch it if it happens again, then I think there's a risk for other areas of not just psychology but medicine as a field. Yeah.
Yeah, it certainly feels like all health professionals ought to be thinking about what are the implications and consequences of this for our professional group.
But I mean, it's very difficult, isn't it, when people don't agree on what's happened? Yeah, and the attempts to, you know, I think the Cass review is without question the best review that's ever been done in relation, without question. You know, it's got flaws, of course, but it's the best review that's ever been done. It was 4 years. It was no doubt millions and millions of pounds and millions of hours of people's time. But you can see real resistance to the findings, some of which are indisputable, you know, and the recommendations. So until we can have some agreement across the board about what's happened, I don't see how we can be accountable.
Yeah. Yeah, thank you, Anna. So GIDS hasn't been the only service where you've worked with people who've had an uneasy relationship with their bodies, is it? I mean, you briefly mentioned your previous work, but I wondered if you would like to talk a bit more about that.
Yeah, I mean, because I think I started in physical health and I've worked at that interplay between sort of physical health and emotional health. I mean, every job that I've worked in really has had a component of both, you know, so lots of the medically unexplained perplexing presentations and physical symptoms with children and adults, you know, different symptoms, but possibly, a lot in common. The eating disorders has gone all the way through. I worked in HIV and sexual health with adults as well. So all of my work, but I mean, less so in private practice, actually, which is a bit more generic and a lot, you know, there's still lots of physical health work, but also, you know, young people and adults with depression, anxiety, OCD, all the bread and butter clinical psychology work. But I mean, from that work, what I would say is that all of our work is, we're working with bodies. Like, you know, we are all embodied, and brains are in bodies, and, you know, maybe because of my bias of working in physical health, you know, just remembering that emotions are an embodied experience and that we can express emotions in all sorts of interesting ways through the body. So yes, I've had a very specialist route in physical health, but in a way, I'd like more people to think, more psychologists in doing therapy, to think about the embodied nature of their clients as well.
Yeah, I think quite often it can get a bit left behind, can't it? And I think one of the conversations David and I had, which has some overlap really, was a forensic case involving Marcus Gustafsson, who was dubbed the eunuch maker by the press. But again, somebody who's had a very complex relationship with their body and was clearly managing to harness the attention of other people who were
Yeah.
uncomfortable with their bodies. But I think the more that you're doing kind of like complex trauma-based work with people, and certainly in forensic services, it felt really important to start thinking about the body, because what no matter what sense somebody can make of things in their mind cognitively, quite often they feel something very different, and unless you can find a way to help the body and the visceral
Yeah.
sense of what's going on synchronise with what's going on in the mind,
Yeah.
people often end up quite stuck, don't they?
Yeah. I mean, our emotions clearly evolved long before our language skills and some of our sort of higher level cognitive functioning, so I think our emotions are so deep, such a deep part of what it is to be a mammal, perhaps, but definitely a human. And yeah, I think as psychologists, we're all quite verbal, aren't we? And quite cognitive. And therapy is usually a verbal exchange. And I think sometimes that's problematic. So I was working yesterday with a middle-aged woman with very significant complex PTSD, and she was really going for a crisis, a very embodied crisis. The classic: couldn't eat, couldn't sleep, the red alert. And she was saying, I know I'm safe up here, but I don't know I'm safe down here. And it was just such a beautiful illustration of how, we've done all this cognitive work, but if the body doesn't believe it's safe, you're still going to have, so many of those symptoms.
Yeah. One of the things I've really enjoyed about forensic work is making sense of things that on the surface seem quite inexplicable. And I wondered if that was part of what you enjoyed about the work in terms of thinking about the body and what might be going on psychically, emotionally, spiritually, that, when actually you're presented with something within the body.
Yeah. I mean, I think it's what hooked me early on. So my first job after my doctorate was in adolescent medicine in Great Ormond Street, working with these perplexing physical presentations. And we use different terms, don't we? Sort of psychosomatic, functional, but essentially working with young people who had physical symptoms that were real, that were either there was no pathology, or the pathology wouldn't explain the severity of the presentation. And I really enjoyed the detective work, in a sense, of trying to make sense of what was happening for these young people, which would sometimes include medicine, so sometimes there would be more tests or brain scans or, other sort of physical assessments that were going on. And then you sort of get that data back and you'd work with the young person and the family, or how do we make sense of this? Because, you definitely have got a chronic headache, but there's nothing that we can find that explains it. And often through the work, I mean, it's why I am so committed now to psychotherapy as an intervention, because it was, despite all of our best medical technology, life-saving and brilliant, often and most of the time, but despite all of that, for some of these young people, it was only through safe, long-term, creative psychotherapy where we could really take apart very slowly what had happened to them, how they were making sense of themselves, that you could sort of start to come up with a formulation or help them with their meaning making about what was happening to them. And it was only once things began to make sense to the young people in the family, so their fear maybe went down, that you could move them into a place where maybe they could start getting better. Yeah, so the detective, it is, really rewarding, sort of watching people begin to make sense of themselves and trying out different things and working with that individual, because they're also unique.
Yeah. So I don't know if you found this too, David, but sometimes it can be quite hard presenting in a team a non-medical model of mental health as a psychologist, as like a therapist. And I suppose I did wonder what it was like trying to do that in a physical health team. I imagine it would be even more challenging.
Well, yeah, I mean, it depends on the team. Some medics and physios and people that I worked with are much better psychologists than me, I would argue. And some psychologists I've worked with are probably, much more medical model. than me. I mean, I think it's really challenging because I was thinking about this. You know, if you've got a young person with a physical symptom in the room, and you know a bit about their backstory, and you might be a lot of work in hospitals is MDT, so co-working, and you might be there as a psychologist, you might have a medic, and you might, you know, you're hypothesizing about what the medic's thinking about the symptom, you know, and then you've got your theory about the symptom, and then you've got the kids' theory about the symptom, and the parents' theory about the symptom. And they might all be aligned and they might all be wildly different. And I think as a psychologist, you're sitting there sort of with all those tensions and thinking, okay, how do, you know, you have to be so strategic, because one of the things about physical symptoms is they are so real and they are so, you know, they're really messing up people's lives. And you can't come in and say, oh, have you thought this might be psychosomatic? Because you will lose them. And rightly, perhaps, you know, because you don't know yourself. But you have to be really strategic and think, okay, well, how are we going to, first of all, get a shared formulation for all of us? How are we going to get everybody's views out into the room? And how are we going to influence this in a way? How can we join? And how are we going to influence this in a way that might enhance health and improve things? So I think a lot of us working in physical health and I'm sure, you know, all professions working, you know, because everybody's speaking slightly different languages. You do have to be quite strategic sometimes, and yeah, and humble, you know, because you just don't know often. Certainly at the beginning, you've got no idea. You know, this could be medically explained, and usually in part is, you know, so it's really complex sort of area to work in. And as a psychologist, you're not always welcome because they came to a physical health clinic, and there's less stigma, isn't there, today? But I think if you are scared of your physical symptoms, you know, you're very, very keen that the medics keep looking at you. And I think it can be scary to be asked to see the psychologist because you're thinking, does that mean you've given up on me? You know, am I safe? You know, so there's a lot to it.
Do you think the reduction in stigma around mental health has made a difference at all to those sorts of presentations, or are we still where we were 20 years ago?
The physical health presentations, or I think people are much more open-minded to the benefits. I think 20 years ago, you know, when I was really starting, people were almost embarrassed to offer psychology, you know, the MDTs. Whereas now I think that's less the case. And I think people are much more aware of sort of body-mind links. A lot of people, I mean, I've got a biased sample, but a lot of the people I work with come to me with theories about that now, whereas I don't think that happened so much at the beginning of my career. You know, we're all really aware, aren't we, of the increase in awareness of mental health problems across society. You know, Lucy Fuchs talks to it in relation to young people and identities and things. But there will be positives of that, I think, in terms of engagement with psychology.
Did becoming a mum change how you felt or about the work that you do, or change how you perform your work?
Yes. I think becoming a parent changes pretty much everything. Yeah, it was interesting because both my kids were born. Well, no, actually, my second child was born after I'd left the gender service, but I was pregnant whilst I was there with both my children. I think, I mean, I've always worked with kids. I come from a family of teachers and a lot of, you know, a family that loves kids. But I don't think it was until I had my own that I really understood, really like how vulnerable they are. You know, how much power we have as adults to shape them in good ways or less good ways. And I think that made me think much more about the need for adults, professionals and parents to make sure that we are that we're attuned to the fact they're not adults, firstly. I mean, one of the things that seems to be going on, Jonathan Haidt's work on, you know, the internet and smartphones and stuff. One of the things that stood out to me from that was the concept of adultification of kids. And it's something I've definitely seen in the gender field with, the consent going lower and lower, and something that we wouldn't have had we wouldn't have been asking 11-year-olds to consent to things without a lot more support in other medical specialties than we were in the gender service. So this adultification, and I think, you can debate Haight's work, but I think he's absolutely spot on when he says on the internet, you don't have an age, and anyone of any age can be interacting, and you can't see and you can't protect the younger people. And I think that has sort of filtered into our society a little bit. And having a baby and then, watching them grow up, you realise how they are children, they are not adults, and they do need protecting. And I think I also learned how little they know as kids. So my youngest son had some night terrors a few years ago, and in them, he spoke about it for ages. These bats came into his room, and he picked up a stone and he threw it at the bat, and it was really vivid, really vivid. And we said, "Oh, it was a dream. It was a night terror. It was fine. It was your imagination." And he was like, "Oh," and I don't know. A few weeks later, we were walking on the road, and he said, "Mummy, why didn't you teach me about imagination?" And you just think, "Oh God, yeah, they really do not know anything." I didn't realise I had to, but they are so open, aren't they? And we have so much power over them. And I think having kids also, in terms of what I expect from services and what, my hopes are from, other services, psychology, medicine, I think I very much now, that protective thing comes in, where it's like, if it's not good enough for my kids, I don't think it's good enough for anyone else's kids. So it's probably made me raise my standards a bit, even more. Yeah.
It's a fascinating way of pushing things. Why don't you teach me about imagination? Because
he was
it takes
so
a life.
angry.
Yeah, but he's got a lifetime to find out that his mind will continue to create fears, anxieties, wonders that from time to time, like all of us, he'll find overwhelming.
Yeah, or we believe. we think are real or true, yeah.
So Anna, you've left the NHS now, is that right? Should I pick that up?
Yeah.
What are you doing now then?
Well, I have left the NHS. I'm still involved with the NHS in a number of ways. I still train some NHS staff regularly, and I work. I provide staff support through the Association of Clinical Psychologists to NHS staff. So I feel and I feel quite connected to the NHS still. But essentially my main role is I'm the director of a private practice based in London. Called the Integrated Psychology Clinic, where we have a number of specialist clinics, and we see people for private clinical psychology, mainly therapy and assessment. Yeah.
So you're leaving the NHS, though, in the bulk of your work. Was that a particular kind of decision that you made?
It was, yeah. I mean, the experience of working in the gender clinic at that time, so this is, I left in 2017, so we're talking a while ago. I was really tired. I limped out of the NHS. And I'd always had a private practice, so I was able to build that, but it was a big deal. We're all trained by the NHS, aren't we? And I think, I'd certainly identified as an NHS clinician, and shared lots of its values and things like that. And it was scary actually, leaving the NHS after a whole career in it. Just things, just really basic stuff like pension, really basic stuff, pensions and the security of sick pay and things like that. But the NHS isn't perfect. You had Dr. Libby Nugent on your podcast, didn't you, some time ago, talking about the deaf mother, which I won't go into, but nothing's perfect. And, there are areas, I've seen amazing practice in the NHS, but I've also seen not so good practice, and a lot of meetings and management structures that were quite difficult to work with. So it was difficult on one level, but it's also been very liberating on another level. And I love my job now, and I love the people I work with in my team. And I think we're able to, it's sad that we can't offer it to everybody, but we are able to offer our patients and our clients really good quality, where it can be evidence-based, holistic, formulation-driven psychotherapy. And I wasn't always able to do that in the NHS. So, yeah, it's been a mixed bag.
Thanks very much.
So I can't imagine it's been that you had an easy time of it working at the GIDS, or even perhaps in some of these other services at times. How have you coped with this experience of those sorts of challenges? How have you kept your own self healthy and nourished?
Well, first of all, yeah, you're right. I mean, I don't think a career working with distressed people or in clinical psychology is for the faint-hearted, really. GIDS has been exceptionalised. It was exceptional, but it's hard work, I think, across the board. And yeah, we don't want to lose touch with that. How have I? I think through relationships, through friendships, through relationships, through my colleagues, through through continuing to think, through continuing to ask questions and annoy people, through being accountable. I think I've had to be accountable to myself and to the young people I've seen over the years, and to use that and to make a decision that decisions that feel aligned with my values. So essentially being honest and connecting with like-minded people and through that, actually, I've received, it's been quite moving, the amount of support. And it isn't just me, is it? There's been a number of people who've spoken out about what happened. And sometimes we get quite a lot of negativity on Twitter and social media, but more often we've had people reach out and be incredibly kind, and that helps.
Thank you. Thanks very much, Anna. And we will share links to your practice, your clinic in our notes, so that if anybody does want to track you down, they're able to do so.
Lovely. Thank you.
Thanks very much indeed, Anne. It's been a real pleasure to meet you and hear about your work. Thanks a lot.
Thanks, David.